Yeah, just my take on things. My answer to number two. Guided discovery. Identifying and challenging your beliefs. Reframing your mind, negative thoughts release. Those cognitive distortions decrease until they cease. Let's go. Guided discovery. Identifying and challenging.
We're recording. Welcome back, everyone, to Peplau's Ghosts, another exciting episode. I am so thrilled. Here at Peplau's Ghosts, we are going international today. We're thrilled to welcome Dr. Cheryl Forchuk, who is internationally known as a world leader in mental health, psychiatric nursing, and actually was mentored under Dr. Hildegard Peplau. So looking forward to her experiences and, working with Dr. Peplau. And just everything she kind of has to share with us. So thank you again, Dr. Forchuk, for joining us. Also joined with Dr. Kate Molino from the University of California, San Francisco, and as always, Dr. Melissa Chapman-Hayes, who is here as well. So I did have, kind of a quick bio, but again, it's just, there's so much to say about Dr. Forchuk, and so I'm just going to kind of get into our conversation and just let her experience kind of show itself. So. In this podcast, we really kind of focus a lot on the idea of psych mental health nurses, especially in advanced practice, doing psychotherapy, and obviously being mentored by Hildegard Peplau herself. When did you first get interested in psychotherapy, either in doing psychotherapy or it's as an intervention within psych mental health nursing?
Well, it's when I first went to nursing school. I remember I actually thought I would like to work in pediatrics when I started, because I had done a lot of work previously in terms of summer jobs at camps and that sort of thing. And honestly, I did not like it when I did it as a nurse, because I hated hurting kids in the experience. But when I hit the psych mental health placement in my undergrad, I knew that was for me. And the other thing at our program, I was at the University of Windsor in Ontario, Canada, we had the option to do, I did a joint psychology and nursing degree when I started. And honestly, I was thinking of switching to psychology, but when I hit mental health nursing, it just really felt like that was home. So when I graduated, I did not even get a uniform because I decided I would never wear a uniform. I'd work community health and I would work mental health, and with mental illness. And my first job was in the addiction field and working in alcoholism. So I had the opportunity to do both individual and group psychotherapy. Was simply part of the role. At that time. And I will say too, when I was working in the summers and was working with youth, in Canada, we had a federal thing where we could start our own businesses and get a grant as a summer job. It was called Youth Opportunities Fund. And so I'd actually set up a program for vulnerable youth. That we're dealing with sexuality issues and addiction issues. So even as a nursing student, we had that project. I was working with other people, and then it sort of led naturally to working in that field. But I enjoyed doing that. When I went back for my master's, though, I decided I in some ways overly focused in the addiction area, and so I wanted to have a broader experience. But basically, I would say I started doing it very early on in my career. Like I say, even in nursing school, just knew that, this is where I belong. This is where I feel comfortable. I love the fact, compared to other areas of nursing, that there's no clear right answer, right? We don't know so often what's going on. And so it really calls for creativity and flexibility. And we talk about patient-centered care in almost every area, but I think it's truest in this area. And I really appreciated those aspects.
Yeah.
Sorry, that's
No, that's great. I just was having this conversation the other day. I think, either people get it or they don't in psychiatry, and there's kind of no in between. I mean, people either like the gray, because you're right. There's no lab, there's no scan that we can kind of just hold our hats on and kind of say, you have this, you have that, or, and this is going to work. It's a lot of, unfortunately, trial and error, and it's a lot of that sort of thing. And so yeah, no, I appreciate that kind of, just finding it and falling in love right away. It's one of those things.
Great, right? I remember was working with colleagues in the UK. We were looking at this proposal. Unfortunately, it didn't get funded. We were trying to have a joint program, and we were looking at the issue of depression. And we found, and there's research evidence of about 200 different causes of depression, right? And so we were thinking it would be a really good course just because you could look at things at the molecular level, the neurotransmitter, the hormonal, the intrapersonal, the interpersonal, the cis community. What doesn't matter what level you look at, you could find causations. But I think it's just a beautiful example of the complexity of the field we work with, and yeah. So if you're not comfortable with complexity and you want clear-cut answers and knowing exactly what you're doing at 10 a.m. on whatever shift, I agree. It's like you either really like that ambiguity, which leads to creativity, right? Like you have to be flexible, you have to be creative, or you hate it. you want a recipe book.
Absolutely. And I just want to say, Dr. Forchuk, it's such an honor to meet you. I know I shared with you over email before we recorded, but I'm a fellow Canadian. I'm now a dual citizen, and I did my Bachelor of Science in Nursing at the University of Toronto. And your work, very much was the foundation for our mental health nursing class. In particular, your work around, applying Peplau's theory and the nurse-patient relationship. And I understand that Hildegard Peplau was actually your mentor. So I would love to hear a little bit about, how working with her informs or has informed the way that you see things.
Well, it was interesting because I learned about her theory in my undergrad. Never thought I would meet her. After I graduated with my master's, I went and worked at a psych hospital. As I said, I wanted to have a broader background and go beyond addictions, even though I love working in the addiction field. And I still today, I'm working on bringing harm reduction practices into our hospitals in London, Ontario, where I'm situated now. But I was the first full-time clinical nurse specialist. Keep in mind, this is quite a while ago. We're talking about early 80s here. And the hospital I worked at actually was for psychiatric health nurses. You should all know about this hospital. It was really foundational in many ways. It was actually the first hospital in the world that was established, and this is back in the 1860s, with a policy of no restraint. So there are other hospitals, like in France, most famously, where they got rid of the restraints. This hospital never had them. So we had people come from around the world to the hospital, and they were really well known for being innovative. It was originally called the Ontario Hospital Hamilton because we had provincial hospitals in different areas. When I was there, it was called Hamilton Psych. It's now part of St. Joe's in Hamilton. But one of the other things that they did prior to my arrival, they were also so always very innovative. They had a working farm. They instead of restraints, even back in the mid 1800s, they were working with patients rather than it was very much a collegial kind of the whole way it was set up, right? It was about having that kind of supportive environment. So this hospital, prior to my joining there, which I joined in 1980, they were the first hospital in Canada that actually required nursing theory-based practice for all nurses. Now, that was originally done with Ida Jean Orlando. It was the first one there, but we had moved to the idea of theoretical pluralism, that the nurse could use whatever theory was important and worked for the particular patient, but they had to actually document it, which theory they were using. And it was part of the evaluation. When you had your annual evaluation, it was you had to be very clear which theories you were able to use. And so as a consultant, a clinical nurse specialist, when I would get a request to, usually in the sticky situations where usual care isn't working, I had to do that consultation based on the theory that the nurse was using. So it was quite interesting. And what I found, despite the fact we'd had Ida Jean Orlando there first, the Peplau's theory was the most common theory. So I was using that theory quite a lot. And we did try to get in various guest speakers from around the world to come in. So I wrote her out of the blue and just said, would you mind coming to our hospital? And I described the hospital, like this would be really good. And we had some of the other provincial psych hospitals were going to do it so that chip in so that she could go to some of the other areas. And we were going to sort of televise out some of the events. And she was going to come for 3 days is what we were proposing. So when I sent that request, she was 78 years old. And she did not have an opening for a year and a half. She was so booked. And then she was saying, now that I'm getting older, I'm trying to put a day of travel in between my speaking engagements rather than doing them in sequential days. But as a result, I'm having to book them so much further out than I used to, which I kind of thought was hilarious. And I have to say too, so I'd when this happened, I'd returned from maternity leave with my first son, and I was planning on having the next baby 2 years later. So I literally delayed the birth of that child. I delayed getting pregnant so that I would be there 18 months. So I had to delay by 3 months to make sure I wouldn't miss this event when she came. And so anyway, she visited for 3 days. We had some presentations. I had different nurses with tough clinical situations that we'd had on various units. And it was marvelous. You could just see her clinical excellence. Like it was just absolutely amazing. But I was 7 months pregnant, keep in mind, too, which does relate to the rest of the story. So anyway, it went really well. And at the end of the visit, she said to me, write me, gave me her address. And she says, I want to, and she said that she was so impressed that, so like she was one of these funny way, sometimes the way she say things, that she can't remember having been in a hospital where so many nurses were approaching competence. So like anyway, I found that funny. I think I laughed when she said it.
That's funny and sad all at the same time, right? I mean, it's one of those things, like it's sad that she's just seeing that now, but that's amazing. Yeah.
So anyway, the next month I went off on maternity leave. And in Canada, keep in mind, we have long maternity leaves and we have parental leave. So husbands as well as wives can get paid maternity leave. So it meant I was going to be like kind of out of commission in that way for a year. Anyway, Christmas came. So my son was born in May. She was there in April. My son was born in May. And at Christmas, I got a call from the hospital saying, we got a Christmas card from you here from Hildegard Peplau. I'm going, oh, that's weird. And so I live out of town. So somebody came, dropped it off. And it was like, Merry Christmas. You didn't write me.
She's holding you to the fire. That's great. That's awesome.
And like it was a little bit intimidating. Oh, the mother of modern psychiatric nursing, and plus, like I'm so kind of I had these two youngsters I was dealing with, and I didn't do it. Honestly, I was a bit intimidated. So I wrote her back and I said, well, I apologized. I said I'm still on maternity leave, but got the letter and, wrote her a nice note back. And then she writes me back again. And the first thing she says, so when are you going to do your PhD in nursing? And so I wrote her back and I said, oh, well, I am planning on doing that. However, at this point in time, because my son was born in 1984, we don't have doctoral programs in nursing in Canada at that point. We were just at the point of planning them. And I have 2 kids under 3, age 3. So I thought those were really good reasons, right? So she writes me back and says, stop making excuses.
Oh my goodness.
That's great. I mean, wow. There's no excuse she's going to take. That's great. That's so great.
And, how are you supposed to get doctoral programs in nursing in Canada if some of you don't leave the country to do it? And kids under 3 are so much more portable than as they get older. This is the ideal time. Because I said, I'm going to wait till they're both in school. She says, you wait till then, they're in sports teams, their schedule is going to dictate. If you go before that, you can just carry them around anywhere.
So was she offering you a slot in her program? Is that what she was doing? Or
no, but she's already theoretically retired, right?
Oh, that's right. That's right. Yeah.
Like I say, she was 70. And so by this time, like she's like 79 or something. So anyway, I did go back with them quite young. I went to Wayne State, but we maintained a correspondence like every week. We maintained a correspondence. My doctoral thesis was on testing her theory, and she was very involved. Like, for example, she didn't have a picture model for her theory, which was something that normally theories have, like they're written in a certain style. But because she had actually written it in the late 1940s, it took her a few years to get it published because she refused to get a physician co-author. And just about everything at that point for a nursing program required a physician co-author. And she that this is supposed to be a theory for nursing, I'm not getting a physician co-author. And so it delayed the actual publication by a few years. But anyway, so I worked back and forth with her on a picture model of the theory, and then we decided what were the most important things in order to test the model. As I say, we were able to get together in person a few times, particularly we'd plan it like at conferences, that sort of thing. Like if she was asked to speak, she was very generous and sometimes suggesting I should also come and talk about the practical implementation, and then that would be an opportunity to get together. So anyway, so we maintained a weekly correspondence. I have binders like this thick that I've kept in terms of, well, I'm sorry, you can't see that. Say several inches. I don't.
No, that's great. Yeah.
Yeah. So anyway, so she, and the other thing she did that was really important and very consistent with her theory, because it's all about relationships, right? She also connected with me with other people, and in many different ways. Like she would say, oh, so-and-so, Phil Barker in Scotland is doing something similar, you should connect with him. You should connect with Bill Reynolds, is doing work on empathy that's related. Grace Sills has done this review. You need to connect with her. So she was really, and she would, and sometimes I would just get letters from people saying, Hildegard Peplau said I have to contact you and ask you about this or that.
I wonder if they got the nasty letters too. Like, why haven't you reached out to Cheryl yet?
Yeah, like I would say nasty so much as firm, which I even remember saying to her, I says, well, your theory is very much about being patient-centered and going with the flow. Like the nurse sets the process, but it's very patient-centered. That I said, but so how come like it was sort of a joke, but yet you're kind of bossy, which kind of goes in a different direction, right?
Yeah, and thank you for correcting me. I think, I think this is what very driven people are. They just kind of they have a passion, and it's like nothing gets in the way. They're just like that. They're going to get it done, and either you get on that bus or you don't. And if you don't, she might kind of drag you along for a while, and until you get the idea that you need to be on that bus. So that's
Yeah, yeah,
awesome.
yeah, but yeah, but yeah. Anyways, it was great to have that opportunity, and it say like she was very supportive in so many ways, like the different connections with other people, et cetera, was really foundational, allowed us to really create a community of people working on similar areas. And a lot of those people I'm still in touch with, the ones that are still alive.
This is so fascinating. Thank you. And given, your experience and these experiences, I'd love to hear more about how you see nursing being a leader in performing psychotherapy.
Oh, absolutely. Because I think we have, because like her form of psychotherapy, as you know, it's not as purely insight driven as many forms are. It's really very much about competency development. This idea of creative, constructive community living is the goal. And the person who does the work, of course, is the person who gains through the work, and that they're identifying what to work on. But in some ways, it's like insight is more the side effect of that growth versus being kind of flipped around in another way. In many models, I think the idea is the focus is on insight, and then the insight will create the growth. But it's about this learning and problem solving and helping them develop these as I say, these competencies of constructive community living. I think it like when you look at a lot of her work, I think a lot of people have done similar things, like even her issues around use of language is very similar to, say, Aaron Beck's work that came after, right? That you're looking for patterns in the language and reflecting back on the use of language, but as a learning tool. But I say, like, I think it's very flexible in that way, because I've worked with people with a wide range. Like in some of the programs I would work with, I'd be working with people with developmental handicap, but yeah, we could still work with where they were at and look at learning and look at constructive community living, or be working with people who also had a PhD and were at a very different. So I think it's very flexible in that way, but also this idea of it being very much about growth. I think that's so much about nursing, is this idea of growth, interpersonal growth, and this development of competencies. And as I say, that's why it was funny, given that being a main part of her theory, when she was talking about that after she met the staff. And I think we actually did have very excellent staff at that hospital. Like of all the provincial hospitals, we had the shortest length of stay, which in Canada is a good thing. Most of our work was actually in the community. Like we had so many more community patients than inpatients. We had the fewest per capita number that were actually hospitalized, because our goal was around constructive community living. So like, as I say, it was just all in all a really good fit. So I don't know, did that answer your question, Melissa?
Yeah, thank you. I've just as the non-nurse, constructive community living, I've heard you say a number of, like, that phrase I haven't heard before.
Yeah, it's in her 1952 book.
Thanks.
Yeah, when she talked about the purpose of nursing.
Yeah, thank you. I know it was one of the things it's coming to fruition too, because I was kind of looking kind of with your past work, and one of the videos I ran across was the doc talks from St. John's, and your talk about homelessness, and I think that constructive community type of involvement with Peplau, just really kind of connects that. And I wondered if you could kind of, again, for our audience, just kind of share that connection with Peplau and how that
Yeah,
really does address
yeah,
homelessness or
yeah, and on different levels again, because one of the things that Peplau talks about, and again, this is important in psychotherapy generally, is about self-reflection as well. It's about understanding there's more than one party. So one of the things Peplau always said was that if you are assessing the patient without, or client, depending on the context, without equal assessment of yourself, at least, you're not using her theory. So the person providing the care and the person receiving the care both need assessment. So what I've done with my research, from a research methods, I always include the people providing direct care as well as the patient experience. And I do a lot of systems related work. Um, and and certainly I have been doing some other work around like the transitional discharge model, which is very consistent with Peplau's model, which was given by the World Health Organization as an example of a model that respects patient rights, because it very much was co-designed with patients and frontline staff. But also my work on homelessness is very much the same. And I was seeing an overrepresentation of people with mental illness, including addiction, in that population. And again, exactly as you're saying, because that runs contrary to this idea of constructive and productive community living. So we've done a number of projects to look at specific subgroups to end it, but all of those include people with a lived experience and frontline staff to co-create what the solutions are. So it's very similar to what we do on a one-to-one basis in therapy, but doing it more on a larger group basis. But it's the exact same process. It's the exact kind of dual involvement with the same kind of goal of this living, and the same thing. I have a process in place, but the actual ideas and the design and what is required actually to set that agenda comes from the people with the lived experience. So we've come up with models like for youth homelessness, people with chronic addiction, family homelessness. I'm right now working on projects related to women veterans who've experienced homelessness. But I always use that same approach. And I was talking about, the study in terms of addiction, that what I've been working on in the London, Ontario hospitals around bringing in harm reduction strategies. But again, the same thing there. We were focusing on methamphetamine because there's not a clear substitute. And hospitals are often the hole in the middle of the donut when it comes to harm reduction. I don't know what it's like in the States, but it's very well accepted in the community settings. And then you go to hospital, it's no, by the way, don't use while you're here. You might get kicked out, which goes contrary. So we were trying to address some of those issues. So we talked to people with a lived experience. What would you want in place? Talk to the staff. What do you see as the issues? And then kind of plan together how we can make the things that happen that are based on what people actually want.
yeah, no, you're absolutely right. The States is very much unfortunately kind of I would even take a step further and say that the patients, their desires or their involvement in the treatment planning has been less and less valued, unfortunately. And so I think that's something that we continue to and again, as nurses, I'll just kind of toot our own horn here. I think that's what nurses do, and that's the role that they, if I ever hear it from anybody, it is nurses that will kind of speak up for that patient and ask that question, like, what do they want? And so
The advocate, I think we can't underestimate the advocacy role of nurses, and we do that on multiple systems levels. And again, when we're thinking of that constructive community living again, we have to, right? We have to do that. We have to speak out with our patients and support them to also speak out, so that we're not taking their voice from them, but amplifying it with them, right? But like Canada as well, I would say, like, our nurses are incredibly politically involved. It's something that we do a really good job of. So have a huge influence on healthcare policy as a result of that. It was quite a few years ago, around the way back when I was doing my PhD, we were revising the Canada Health Act. And at that point, one of the things, like, because there was the possibility at that time of physicians extra billing over and above the free healthcare that everybody's entitled to, paid for through taxes. So it's not free. And the nurses wanted to close that gap and say, no one should be able to jump the queue. And of course, all the physicians wanted the ability to earn extra money. And the provinces thought that would be okay. But the nurses lobbied very strong. In fact, during the one meeting, we had it strategically across the whole whole country, where every 5 minutes we sent telegrams, that everybody was receiving these telegrams from different nursing groups across, and all day. So at the end of the day, that was essentially made illegal. That if a physician, let's say, charges you an extra $100 to get some medically necessary procedure earlier than someone else, that means the province, for the federal funds to go from the federal government to the province, gets $100 less, and they know who it is that did it. So they're in trouble. It really closed that. It really closed that gap, but it was nurses that did that. And some people say we when we were making those changes, we had little buttons made up saying nurses know, nurses care, nurses vote, because in Canada, nurses are one of the groups that have the highest voting rates of almost any other profession. And then we'd say about, for each province, how many voters are nurses. So it makes a very clear message. You better pay attention to the nurses.
I love this piece about, how important the advocacy is, and nurses as a formidable political voice. I think that's so important. Yeah. And so, Dr. Forchuk, I'd like to ask you, which I think is maybe our final question, which is, given everything that you have learned, that that you've shared with us, how do you see sort of the future of mental health nursing, psychotherapy unfolding, given all of the challenges that we have in today's world, some of which you've talked about already?
Yeah, well, some of the challenges that I've worked on as well is the issues related, I would say, well, there's two issues. One of them relates to short length of stay, because like our length of stay is not based on an insurance program, but it's more similar to an HMO. So you get the hospitals have a blanket amount for the area they serve. So if you have a fast admission, then it's better for them. And so sometimes you'll hear people say, well, if they're in on a short admission, it's difficult to form relationships. But so that's some of what I find when I'm talking to staff now, that we have to really look at. And sometimes it's about setting the person in a position. Maybe that long-term relationship is going to be with the community nurse. Maybe it may not be with the hospital nurse, but you can still set them up in a position where they trust nurses because of what you started with them, so that they can transition that relationship to the community. The other thing is around technology. And so I've been very involved in some of our projects looking at how do we have technology for solutions that support the therapeutic relationship rather than get in the way. And so we've been looking at, and I think that's really, really important. And if we're not involved with that, then these tools will be developed that do not support the relationship. For example, if we were one of the things we had done is we'd worked on a phone app, and like I remember when we were looking at like mood monitors, there was like over 200 out there at the time. I'm sure there's many more now, but only 6 had ever even been tested. But most of them focus on introspection. Like you're doing this in isolation, you're focusing on the scale. And we know that introspection and depression without a connection with another person is not really a good thing. But that's not how they're being evaluated. So what we've done is look at things where the client can be empowered by seeing all their own data, but there's it connects with that healthcare provider, with the nurse, most often, but also could be a social worker or someone else. So that it supports the relationship. And so, for example, if they're doing a self-assessment for depression, for example, that it's negotiated between them. At what point should the care provider get an alert, right? So some people are depressed all the time, and maybe it's when it starts going up, then you need the alert, right? But so it's a negotiated thing, and there'd be these alerts, but it'd be completely transparent. And it gave them things such as it was updated twice a day. So if they had a medication change at 11, they could see it on their phone at noon. It was noon and midnight that it would get updated. So they had complete control. They had their crisis plan was on their phone, their medications, the various treatment objectives, and they could create their own scales of what they were monitoring, but it would be all in communication with their care provider rather than purely them focusing on their own. And this was people with serious mental and schizophrenia and major mood disorders, right? So you want it to be this, so I think that's an example. I think with the technology, my fear is that if we aren't involved with that and do it in these very therapeutic, supporting of therapeutic relationship ways, we're going to end up with these things that are going to interfere with those relationships. So that, and as I say, the short length of stay that and those transitions between services, I think we have to pay attention to as well.
Yeah, I love that. That technology kind of adds to the relationship. There's a way of kind of doing that with without just kind of making it, for lack of a better term, kind of just more medical model where we're just kind of checking boxes, we're looking at symptoms and making diagnoses and such. So yeah, thank you. Yeah, sorry.
Yeah, no. I say like we had a lot of people would say when they would have the therapeutic meetings, it was more focused because instead of saying, well, how's it been going? They had that information and the patients were able to look at patterns themselves. Like, hey, you know what? I notice I'm most depressed on the days I'm not doing activities, or the day I talk to my mother, or whatever. And I remember a couple of them said because they were also looking at things like blood. Every time my blood glucose goes down, I'm depressed. And then realizing that that's in fact what they had to deal with. So they could have like this little experiment of one, because they could plot those two things together and say, oh my goodness, there's my blood glucose level and there's my depression level. And then when they come in, it was very focused saying, you know what, I've totally been missing this.
Yeah, something, they feel seen, they feel heard, they feel a sense of control. There's something I can do to ameliorate these symptoms, and that can be a real sense of power for a patient. So yeah.
And very focused discussions when they would get together. They both have the same information and they're saying, oh, I want to talk about this.
Yeah, excellent. Okay. Well, I love that future. That's awesome. Thank you, Dr. Forchuk. Thank you so much. And thank you for those listening. I hope everybody's learned a little bit of something, had some fun. I definitely, for me, kind of going back on what we talked about a little bit today, you mentioned, Dr. Forchuk, about the idea of these open units, and that's something that I actually experienced in Iowa City here. We had, I should say, unfortunately, the hospital shut it down, but it was this open open psychiatric unit, which was just kind of mind blowing at the time that you would actually have a psychiatric unit that wasn't locked. And so
Really?
didn't use restraints. Yeah. So very, very novel. And I hadn't seen or heard of anything else, at least in the United States. So I'm interested that they've had that in other places and around the
Yeah,
world.
1860s.
Yeah, right. I know. Yeah, it's a blast from the past at the very least. So, but that's great. And thank you again for sharing your stories about Dr. Hildegard Peplau. I love the idea that family planning got involved with your first meeting with her, and how you just kind of kept connecting with her. And so I'm hoping that that's what this podcast does for people is continue to connect, like-minded people that we, can all kind of stay connected. So my last plug will be to subscribe, like, comment. Please put comments and let us know who you want to hear from next, or if you want to hear from Dr. Forchuk again, maybe kind of make that plea and see if she's available again. So thank you so much, and look forward to another episode coming soon on Peplau's Ghost. Take care.
Bye.
Emotional reasoning. Too much salt like this, too much seasoning. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. Guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease. Yeah, guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease.